Is that the hand on?
Yes, sir.
Good afternoon, everyone. Welcome to this edition of the Black Health Trust. And we're going to invite our co-moderators to help us with the presentation today. Unfortunately, our speaker for today, his wife last night went into labor, delivering him a new baby boy. So he will come back to us in November. But in the meantime, we're committed to talking about the whole story. But before that, uh, and for Dr. Walk's sake, I had an inspiration to read the 23rd Psalm. And the Lord is my shepherd, and I shall not want. And I actually went to the resources and the commentaries in the Bible, and I particularly picked up the one of Matthew Henry to have that explained as the article of faith and what we hope for and how God can be our shepherd and goodness and mercy shall follow us all of our life. And we know this morning there was a tragedy in Michigan where there was a big shooting at a church of Latter-day Saints. That means Mormon. And I think there was also some kind of tragedy in New Orleans too, but I didn't get details on that. So we are praying for our fellow citizens and hope we get some degree of sanity coming up. So I didn't go to church, Dr. Walks, but I did go to church privately. So is Dr. Neighbor Stevens on?
I don't see her.
Okay. So let's go with our first slide, and I'm going to invite you and
So,
Dr.
so, Dr. Maxey, before you get away from the 23rd Psalm, one of the most important parts of that Psalm is the part about walking through the valley.
of the
So,
shadow of death.
so when you get into a bad place, two very important things. One is you're not by yourself, the thou art with me part. And the second thing is, got to keep walking. You're not supposed to buy property and build a house in the valley. Yea, though I walk through the valley. So I think it's important for us when we look at scriptures or any other inspirational content that we really dig into it in a way that is useful all the time. And for me, that's the part. Not by myself in times of trouble, and I got to keep moving through it. So that's what I got
Yeah.
for you, Dr. Maxey.
And it is the valley of the shadow of death, not necessarily death itself, but the shadow of death. So our title today, we're going to talk about the cardiorenal metabolic syndrome and risk reduction. But more importantly, we want to tell the whole story. And the whole story, I hope, will lead to some better understanding of how things happen. So this is basically a story about inflammation. So let's go to the next slide, Simon. So all these things are interconnected, and there's a triangle. So we know that obesity, diabetes, kidney disease, and heart disease all fuel each other. They're connected. They're shared drivers: high blood sugar, high blood pressure, unhealthy weight, and chronic inflammation. So we're not just talking about weight alone. So it's very important that we know how important these medications are. And so importantly, these modern medicines target multiple parts of this cycle. So I'm going to ask Dr. Hines if she would do this slide.
Sure. So the interconnected triangle, right? We've got obesity, diabetes, kidney disease, heart disease, all fueling each other. So Obesity makes you more likely to have diabetes. Diabetes makes you more likely to have kidney disease, as well as heart disease. And then you could also kind of do it in the reverse order too, right? So people who have heart disease are more likely to have kidney disease. So that's how they kind of fuel each other. And then high blood sugar. Part of the reason why diabetes is called sugar is because sugar oftentimes leads to obesity, not because it's inherently the sugar itself um, that was the problem. And then we've got high blood pressure, unhealthy weight, and chronic inflammation. Sugar also is can cause inflammation issues as well. So all of these things kind of work together and feed each other. And modern medicines are now starting to target multiple parts of this cycle instead of just one at a time, which has traditionally been the space where most medicines lie. Some have a little bit of benefit in other categories, but traditionally it's been to target one thing at a time.
Okay, take the next two slides. You're on such a roll.
So now we have medicines like the GLP-1s, the Ozempics, the SGLT2s, which is Farxiga and Corindia. So these are all the weight loss medicines that people are clamoring over and figuring out how they're going to mortgage their home and stuff like that so that they can get it, right? And part of the thing that makes them so potentially exciting is they do more than just control, because they started out as diabetes medicines, right? They do more than just control sugar or weight. They have also been found to reduce risks of heart attack, stroke, kidney failure, and then morbidity, or the sickness and the hospitalizations that are associated with having some of those chronic conditions. They've also been found to reduce general cravings for other things that people kind of get addicted to, right? So there's a potential role for them with substance abuse and alcohol and stuff like that too. So in the context of the disease kind of ecosystem that we're dealing with, they do not work one for everybody, and they don't work alone in the sense of you still have to do something, right? Other than just give yourself the medicine, you still have to, adjust your diet, exercise, get good sleep, work on your stress management, right? Because remember, your food intake is only part of the issue here. And all of these other things, the nutrition, the exercise, the sleep, the stress, if they're still working against you, then the Ozempic and the Farxiga is not going to be able to overcome other bad habits.
No, thank you. So we're going to go to the next slide. So we're going to talk about not only weight loss, but we're going to talk about how to protect your organs. And talk is divided into three parts. The first section is about GLP-1s, such as the tirzepatide medicines. These are weight loss, as well as cardiorenal and stroke protection. The second section is about SGL2s inhibitors, such as Farxiga, as well as Corindia. These protect the heart and inflammatory focus. And also the third section is going to talk about how cholesterol plays a role in this. So why are we going to talk about these medications? So obesity affects the heart, the kidneys, liver, as well as the brain. Next slide. So modern medicine can help people lose 10 to 20%, 22% of body weight on average. And they also reduce the risk of heart attack, stroke, kidney disease, as well as sleep apnea, which can cause a problem as well. Let's go to the next slide. So, Dr. Walks, would you take this?
Absolutely. So, what do GLP-1 and GIP mean? GLP-1 is glucagon-like peptide 1, a natural hormone that helps control appetite and blood sugar. GIP is glucose-dependent insulinotropic polypeptide, another gut hormone that works with GLP-1. The medicines copy these hormones to reduce hunger and improve blood sugar. Next slide, please. Oh, okay, I'll continue, Dr. Maxey. What does MACE mean? MACE, major adverse cardiovascular events. This includes three big problems: heart attack, stroke, and death from heart disease. In the quote unquote select trial, semaglutide or Wegovy cut the risk of MACE by about 20%. Next slide, please.
Go ahead.
Okay. Protecting the kidneys. Flow trial. Ozempic or semaglutide reduced the risk of kidney failure or death from kidney or cardiovascular causes by 24%. This means fewer people had dialysis, kidney failure, or died of kidney problems.
Is
Next slide.
Dr. Lawson on?
I'm sorry, Dr. Maxey?
Dr. Lawson on?
Dr. Lawson is on.
Good morning, Dr. Lawson. Would you mind taking this slide? About stroke?
We need to get Dr. Lawson unmuted. You had it and it went away. One more time. There we go.
Okay, stroke and heart attack reduction. In select people taking semaglutide had fewer strokes and heart attacks. Example, if 100 people at risk took semaglutide for several years, about 3 to 4 heart attacks or strokes could be prevented.
Okay. So diabetic retinopathy, that's the blood vessel disease of the eyes that happens in diabetes. And sometimes that can get worse, especially if you do it too rapidly, taking these GLP-1s.
Is that
So
the next slide, Dr. Maxey?
the next slide, yes. Next slide, Simon. So the small blood vessels of the eye are called retinal arteries. And in diabetes, when they're affected, it's called diabetic retinopathy. And it's damage to the small blood vessels in the eye's retina, the back of the eye. And you might get blurred vision, dark spots, trouble seeing at night. And this is a risk of being studied. But people with eye disease require frequent eye examination by an ophthalmologist. That's an MD eye doctor, not an optometrist or one of those guys. You need an ophthalmologist to look at that. And in fact, that's why I need so much assistance sometimes reading these slides. I had diabetic eye disease. Dr.
So Dr. Maxey, before we leave this slide, because it is so important and vision problems can be so debilitating, I think when we say damage to the small blood vessels in the eyes, aren't we kind of talking about little tiny strokes in the back of the eyes where the blood vessels bleed and things like that?
Exactly.
Because
And
I'm a psychiatrist, so I need you other doctors to make sure that I'm understanding things in a way that I can explain them to people. So when we say diabetic retinopathy, we're talking about the blood vessels in your eyes actually breaking down
yeah.
and messing up your vision, right?
So Dr. Walks, what's so important about what you're saying? If you look at that eye, that is a picture of what is happening in your heart, your kidneys, and all the rest of your body early. In fact, we wrote a book when I was a fellow called the Renal Retinal Syndrome, that you can almost set a clock by when you see retinopathy, that you start to see proteinuria in your urine within about 10 to 12 years. So it's a clock on that. So Dr. Hines, we want to comment on that further? This is very important.
I think if anything, I think it's to your point, like you were talking about earlier. There's how the damage arises, but there's also how the damage affects your quality of life, right? And I think that oftentimes, that you need to go to the eye doctor for get your diabetic eye screening when you're not having any issues or not having any problems or don't feel like you are. It doesn't feel like something that's important to do. But to your point, unfortunately, by the time somebody starts to see something, the train's already left the station. So it is important to do those screening tests, so that then we can make interventions as soon as possible.
But I like that characterization Dr. Walsh said about little strokes in the back of the eye. That's, I don't know how
And
medical works, but
let me just add to that, Dr. Maxey, that a lot of times we think that when something goes wrong and we go to the doctor, there's either a pill, a procedure, or a process that'll make it all better again. And diabetic retinopathy, even though our bodies try really hard to fix the things that we mess up, they do try to heal. Some things like damage from diabetes, really hard to get things to go back in the other direction. So, to Dr. Heinz's excellent point just now, go before you feel something bad.
very good. Dr. Lawson, take the next slide. It's not too far from the brain.
Lupus nephritis. Lupus nephritis, kidney inflammation caused by lupus, which is an autoimmune disease. GLP-1 drugs are not approved yet for lupus nephritis. Early research hints at anti-inflammatory benefits, but also there are rare reports of drug-induced lupus. Standard approved treatments of voclosporin and belimumab, sorry for that, which are lupus and benelysate.
Take the next one to Dr. Lawson if you would. Next slide.
Me again, okay. GLP common side effects: nausea, vomiting, diarrhea, constipation. Less common: gallstones, dehydration, and rarely pancreatitis. These is start at a low dose and increase slowly to reduce the stomach upset. And I might add again, there are some people who say they want to try to override these medications and see if they really do stop you from eating. And that's when you get the problems of the diarrhea and the vomiting and so forth.
And that thing about increasing slowly, that's also if you increase them too fast, that's how that retinopathy may get exacerbated or made worse as well.
So let me once again jump in, Dr. Maxey. One of the words on this slide we really need to focus on, and that's dehydration. Because one of the ways that these medicines work is to let the kidney just push all the sugar out, and some of the medicines work that way. But all of these medicines, all of these efforts that we're talking about, we really have to make sure we are taking in our water. Help our kidneys. They love water. And you say, well, what if I drink too much water? You got to really drink a lot of water to drink too much water. So dehydration is much more of a concern than I'm drinking too much water.
Thank you. That's perfect. That's perfect. You want to continue with the next? Go ahead, Dr. Hines.
I was just going to add that this is another one of those instances where more is not always better, right? So oftentimes I think we have this tendency to think that if we go faster, do more, turn it on high, right? Then we'll get to the end result quicker. And sometimes that's just not what happens. Part of the ways that GLP works is an overall slowing of your gastric motility, meaning the stuff that you're taking in doesn't naturally move along the pathway like it usually does, right? It slows down and sometimes it just sits there, right? Which is part of the reason why you get some of the nausea and the vomiting and the diarrhea and the constipation, because things are not moving the way that they're supposed to. And if you abruptly give your gut signals to say, hey, right, stop moving altogether, you can really get into people have gotten into a world of hurt with things like gastroparesis, which is basically your digestive system gets paralyzed, right? So it and I think it's extra important to talk about this because there are so many ways to get these medicines online and from sources that may not have your personal best interest as opposed to a sales interest. So I think it's really, really important that you understand the good that they can do, but also the caution that needs to be applied if you're using these.
And the other thing is the use of these compounded things that come from sometimes necessary type pharmacies. They try to make it the brand name. And I've always been a brand name fan. Give me the real deal.
So since you mentioned it, can we just speak to how that came to be?
Yes.
So so we all remember when the Ozempics and things like that were hot news, and then everybody was trying to get it all at the same time. And then there was a shortage. And so because there was a shortage, that allowed other manufacturers to make compounded versions, meaning they couldn't make the branded, like I can't just immediately remake your branded version, but I can make my own mix, because once we know what the formula is, we generally know what the formula is, right? Um, and so now, because the shortages have ended, some of those compounding entities are no longer going to be able to dispense those medicine. Think about some of those commercial agents, like the Hims and the Hers and things. They were selling compounded versions of the GLP-1s. They are not inherently bad, right? Just because it's compounded does not mean that it is inherently bad. It's just, it has an asterisk, because compound pharmacies, they exist because sometimes people have medications that you just can't go into CVS and get, right? You need special things or special circumstances. So that is why compounding pharmacies exist. But they also are not subject to the same type of regulation as your more traditional pharmacies. So that's where Dr. Maxey is saying that they've also found that there have been some issues with some of the compounded versions of some of the GLP-1s that have come out. So like most things, nothing's all good, nothing's all bad. You just have to pay attention and be knowledgeable and strategic about what you're doing and what you're getting.
So I have something that is all bad. Um, every, I, Dr. Maxey, I try to go to church every week, but every once in a while, there's somebody at church that ain't acting right. And I don't mean they're not singing the hymns and they're not amening on time. I mean, every once in a while, somebody comes to church with what they think is good news. 2 weeks ago, we had a gentleman come to church to talk about how much weight he had lost in the last month. Of course, when I was talking to him is when they called Dr. Walks to come to the back because he fell out on the choir stand and they had to take him out the back way and then call me. First of all, if somebody is calling me as your doctor in an emergency, that's a problem. But his message was that he had lost 30 pounds in the last month.
Oh my goodness.
When people are trying to lose weight and they lose a significant amount of weight in a short period of time, maybe part of it is their GLP-1 or some other new great drug. I bet that a lot of times part of it is that they're really dehydrated. And so you really have to don't be excited about great results. I've lost 60 pounds in 60 days. No, that's really not the best way to lose weight. And so when that's your report, when that's the result of whatever it is that you're doing, you really have to be talking to your provider, your practitioner, your prescriber, and you really have to realize that that's not good. So it's always all bad when your results are always way too good, way too good. So, but I still go to church, Dr. Maxey.
That's a good point. Good point. Dr. Hand, go ahead with the next slide, if you would.
So who should not use these medicines? So people who have a personal or a personal history or family history of medullary thyroid cancer or MEN2 syndrome, if you are pregnant or breastfeeding, and you would want to use caution in people with severe stomach or pancreatic disease. And again, for the reasons that and the reasons for these particular populations is because if you're pregnant or breastfeeding, this is not the time to restrict your calories, right? Because you need to take in the proper amount of calories to either support the growth of a baby, or in the breastfeeding case, to support making enough milk, right? And dehydration and all those things, you don't have any room for that. And especially pregnant and breastfeeding, you're already at risk for some gallstone. You're already at risk for some of the same things that are already there to begin with. And same thing with the severe stomach and the pancreatic disease. If you have pancreatic disease and then you go ahead and get gallstones on top of that, well, you are now in a world of hurt, right? So literally. So again, and then for the people who had the thyroid cancer and MEN syndromes, again, these are things that would particularly exacerbate those. So that's why those particular groups are called out.
Thank you. Next slide, Dr. Lawson, if you would.
How much risk reduction do we see? Heart attack, stroke, cardiovascular death, MACE, about 20% lower risk with semaglutide. Kidney failure, cardiovascular kidney death, 20% lower risk with semaglutide. Sleep apnea severity, big improvement seen with tirzepatide, Zepbound. Weight loss, semaglutide, 15%. Tirzepatide, 21%. Liraglutide, 6 to 8%.
Okay. All right. There's some mental problems with sleep apnea, correct? So there's a psychiatric risk with sleep apnea?
Sleep apnea is associated with increased risk of major depression. There's been an association. How much it was there is questionable. It's also been associated with people who have mild cognitive impairment as well. So you're helping the brain as well as helping the rest of the body.
Okay, thank you. Dr. Walks, you do this?
SGLT2s, Corindia, and inflammation in cardiorenal metabolic health. Next slide, please. All right, SGLT2 inhibitors. We have SGLT2 is sodium glucose cotransporter 2, a kidney protein that reabsorbs sugar back into the blood. Medicines that block SGLT2 make you pass extra sugar and salt in urine. Therefore, you have lower blood sugar and some mild weight loss. Common SGLT2 medicines are empagliflozin. Last week, Dr. Maxey said he wasn't going to have us pronouncing all these big words, because Dr. Maxey has a PhD and went to pharmacy school, and Dr. Lawson has a PhD. Some of us, anyway. So Jardiance is that one. Dapagliflozin, Farxiga, canagliflozin is Invokana, and ertugliflozin is Steglatro. And these are the SGLT2 inhibitors.
Go ahead with the next one, Dr. Walks. You're doing well.
Thank you,
Let me ask
teacher.
Dr. Wilson, why we make these words up so hard to say with a thick tongue?
I don't understand. I think the best doctrine is done with small words that people can understand, but that's just me. SGLT2s, use indications. So for type 2 diabetes, these medications can lower A1C and reduce heart kidney risks in many patients. And just to say that when you are a type 2 diabetic, you really want to pay attention to what's happening with your A1C. It's different than today. This is what my blood sugar is. A1C kind of tells on you because it tells what you've been doing for the past X number of days or weeks. So you can't just eat healthy the day before your doctor visit and go in and say, oh, the one thing the doctor's caring about, the A1C, is going to be low. You're not going to trick your doctor. So A1C is very useful with your doctor or your practitioner understanding how best to help you. Chronic kidney disease, CKD, slow kidney function loss, and they can reduce kidney failure risk, CKD with or without diabetes for dapagliflozin. And I don't know if we can talk enough. Maybe we can, but I don't know if we can talk enough about doing things routinely because you're supposed to instead of waiting until you feel bad. Your kidneys begin really breaking down, and they don't call you and tell you that there's a problem with your kidneys. You don't really know that your kidneys are having trouble. So I think, I don't know how many times we need to say it because people in our communities continue to have all of their critical functions break down over time without noticing it, because the regular checkups are not being done. Anyway, heart
And
failure. Fewer hospitalizations and better outcomes are what you can get with these SGLT2s, M, empagliflozin and dapagliflozin.
so the reason all this is so important, Dr. Walkson, for our listening audience, is I think if we understand these things, it's much better to know what to take, how to take it, what to speak
Yep.
to your doctor about, not just these long, hard words, but they actually benefit you. Let's go to the next slide. So we know that SGLT2s benefit the kidneys and heart. In the kidney, it reduces the pressure on the kidney filters. It restores tubule-glomerular feedback. So the tubules are the main part of the kidney along with the glomerulus, and that's very important. And lowers albumin, which is a type of protein that leaks into the urine. And we want your doctor to do something called an albumin creatinine ratio so he knows how much protein is in your urine. And I tend to start people on these SGL2s the minute that number gets above 30 milligrams in the urine. That's very important. We know that in heart, it gently helps you lose water and salt. That reduces your fluid overload, reduces the edema in your feet, reduces your heart failure if you have it, and it gives you more heart energy to use, and blood vessel function is better. And the whole body, it has lower uric acid and inflammation, and signals a small drop in weight and blood pressure, all of which are very important. Uh, Dr. Hines, you take this one?
Sure thing. So benefits in numbers. So major heart and kidney outcomes. About 20 to 30% of a relative risk reduction across multiple trials has been demonstrated um, by outcome with the use of these drugs. They found roughly 25 to 35% decrease in the risk of heart failure related hospitalizations with the use of these drugs, and a 30 to 39% lower risk of progression of chronic kidney disease to kidney failure with the use of these drugs.
Go to the next slide if you would, Dr. Hines.
So the safety and what are we what's to watch for if you're using these? So genital yeast infections, they are common, but they are usually mild and treatable. Volume depletion, we've talked about this before as far as dehydration, right? And the biggest sign there is going to be feeling lightheaded or dizzy. So it's very important to stay hydrated. And also, if you're on diuretics, whenever you're on diuretics and taking any of these types of medicines that are going to reduce your intake, you also want to, be sure to review with your doctor your diuretic use, right? Because you're not intentionally saying I'm actively setting out to take in less fluids, but you're not likely to want to take in anything, right? So that can easily lead to unintentional dehydration when you couple decreased intake with enhanced output. So Rare diabetic ketoacidosis has been found even when you have near normal sugar. So usually diabetic ketoacidosis is an issue when you have a sugar of 500 and your body's in such a toxic state that you get to ketoacidosis. But with these, they're finding that people are having incidences of ketoacidosis and their sugars are not astronomically high. And the big signs of that are usually profound nausea, abdominal pain, and that can lead to very serious illness and or surgery. And then canagliflozin had earlier signs of issues with fractures and amputations, and the current labels just emphasize the risk of awareness and foot care. And then again, like we're talking about with doctor, as we've been talking about as far as prevention. I mean, when you get a diagnosis of diabetes, having given people a diagnosis of diabetes and then proceeded to lay out all the people who you now have to see. You got to go to the eye doctor, you got to go to the foot doctor, you got to go to the nutritionist, the diabetes education person, maybe the endocrinologist. Like it can feel like, wait, what? And then just that diagnosis alone just bought me like 4 medicines, right? Because now I got to take, cholesterol medicine and I got the diabetes medicine. And like, it can absolutely be a lot. So I am not making light of how it can feel overwhelming to kind of make time for all of these things that seem, but I feel fine. Why am I wasting sometimes a half a day, right? To go to a 15-minute visit, but but it's important in the long run.
Go to the next slide, if you would, Simon. So these SGLT2s versus GLP-1s, they're on the same team, but they have different things that make them worthwhile and strong. So the SGLT2 is the strongest on kidney protection and heart failure outcomes and for modest weight loss. The GLP-1s, such as semaglutide, are strongest on weight loss and atherosclerotic events such as heart attack, stroke, and high risk. In fact, we benefit from taking all of them at one time because it gives you a good accounting against heart disease, kidney disease, as well as things like strokes. So in the next slide, it talks about cardiorenal metabolic syndrome. All these things are a triangle of conditions where obesity, diabetes is straining the heart and the kidneys, and each organ worsens the others. So they're all interplaying like a tangle of dogs fighting each other. So they're shared drivers: insulin resistance, high blood pressure, high lipids, chronic inflammation, RAS, or renal angiotensin syndrome, overactivation, and treating the whole triangle: weight, blood pressure, lipids, inflammation, glucose reduces events like heart attack, stroke, and kidney failure. They're all very important, and you can't treat one without effectively doing something with all of them. Dr. Lawson, will you take this slide? The next one.
Corindia phenylalanine anti-inflammatory, that's anti-fibrosis for kidneys and heart. Class, non-steroidal mineralocorticoid receptor antagonist. Indication in adults with type 2 diabetes plus CKD to reduce risk of sustained GFR decline, kidney failure, and CV events. How it works, it blocks mineralocorticoid receptor signaling that drives inflammation and scarring in kidneys and heart.
You want to take the next one too, Doctor?
Sure. Corindia, what do the studies show? Outcomes are fewer kidney disease progressions, fewer cardiovascular events in pooled analysis, that's in the Fidelity trial. How it's used consistently is added to an ACE inhibitor or ARB and can be combined with SGLT2s and GLP-1s. Main safety point is this higher potassium, blood potassium needs to be monitored, and also kidney function needs to be monitored regularly as well.
Thank you. So inflammation, that's the common thread. Next slide. We know extra fat tissue can become inflamed. Immune cells release signals such as TNF. And remember all the stuff we used to talk about when we had the COVID active, the IL-6, all these things were the cytokine storm that happened in COVID. Well, this happens every day when you have inflammation. So COVID just brought it to the forefront. So the kidneys, there's inflammatory actions that lead to scarring and fibrosis, and this makes your kidneys fail, have a decreased EGFR or kidney function. And the heart, inflammation worsens, you get heart failure and plaque instability. And we talked earlier to one of our guests online about their calcium score. When that plaque gets there, it catches calcium, and that makes it more inflamed, and that makes your calcium score go up. We know that hormones pathways like the mineralocorticoid, that's Corindia, receptor, they amplify this process, and drugs like phenytoin, which is Corindia, turn it down. That's very important to do that. So, how do we treat inflammation here? We know that lifestyle is important, weight loss is important, physical activity is important, and plant forward diet is important. Sleep, which I need, and smoking cessation. I don't understand how anybody smokes nowadays and after knowing these things. These lower your inflammation markers are very important. The SGL2s reduce kidney and heart stress and inflammation signaling. GLP-1s give you weight loss, and this is anti-inflammatory itself. Corinne directly blocks receptors that drive kidney and heart failure and fibrosis. And statins, we have to talk about those too. And ACE inhibitors all help these vessels. Uh, Dr. Walks, will you take this one?
Putting it together, talk with your clinician. TD2, CKD often start with ACE inhibitors, ACI, ARB, add SGLT2. Consider finerenone, add GLP-1 for weight, cardiovascular risk, and glucose control. For heart failure, SGLT2 for all ejection fraction ranges, add other heart failure medicines as needed. GLP-1s help weight and cardiovascular risk where indicated. Obesity with cardiovascular disease, GLP-1 for weight and MACE reduction, and consider GLT2 for kidney and heart benefits. Yes, talk with your clinician because that's a whole lot of initials and a whole lot of abbreviations. And for those people who want to just go online or chat GPT and figure it all out yourself and then call a compounding pharmacy and order it yourself or get it shipped to you from some other country, just do what Dr. Maxey says. Just talk with your clinician. Next slide, please.
You want to
Okay.
talk about that?
And, and
We had, we actually skip this.
I might have diabetic eye disease, Dr. Maxey, because I'm not okay.
I was going to say Dr. Hines is a bit younger than all of us. You want to take that, Dr. Hines?
Sure. So safety reminders, right? Tell your clinician about all medicines and supplements.
Yes.
And I
Yes.
can't emphasize this one enough, especially because as Dr. Walks was alluding to, currently you can go around your primary care provider and get some of these medicines directly. And especially because some of the insurances are not covering them, so how you're getting them outside of insurance anyway, so why do they even need to go to my doctor, right? But please make sure you tell your clinician about all the things that you're doing, either and all the things that you're taking, and make sure that you want to make sure that you're getting an objective opinion on how to go about some of these things based on you specifically, not an algorithm or a note card that says, oh, if this, then that, right? So that's really, really important. Know the sick day rules for SGL2s and making sure that you what to do. And that just means like if you're sick, should you be taking your medicine or that type of thing. And then you want to find out if you're having any surgeries, what are the recommendations as far as, should you stop them? How soon before your surgery should you stop them? You want to make sure that you have regular labs for kidney function and potassium, especially if you're on finerenone, and then eye exams for people with diabetes, excuse me, especially for those with rapid glucose improvements. Uh, I just also wanted to add to, we often say talk to your doctor about, as if, asking for it necessarily means that you can get it, right? And this is definitely one of those drugs, because you were hearing a lot about this in the news, where it may or may not be covered. And even if it is covered, you're likely going to have to either go through some, depending on your insurance, you may have to go through some prior authorizations, or what they call step therapy, meaning you had to try this and this and this before you got to that. And I'm just putting that out there so that there is setting expectations, right? It does not necessarily mean that your doctor's not doing right by you if they can't necessarily get right to here on the first shot. So just making sure that you are aware of your pharmacy benefits, talk to your case managers and things like that at your with your payer and with your insurer, if you find yourself in those scenarios. So you will need advocates.
Yeah, let me also add the point that you mentioned in terms of supplements. People tend to forget, even though stuff is advertised on the TV and radio and online, does not mean it's going through a clinical trial or even that it's safe. There's too many cases and of these supplements being used, sometimes inappropriately. Some of these folks will come out and say this is as good as that FDA approved stuff, when it's in fact it might be, frankly, just frankly toxic. No one's discovered it yet. And when you get folks are getting medications from other countries, bring them over and so forth, that's fine if it's a country that has a very strong regulatory system. But in many countries, the multiple studies have shown that if you go out and test what's actually in some of these our medications from other countries, it's not what they say it is. Sometimes it's nothing. Sometimes it's placebo. Sometimes it's toxic. Sometimes they got high levels of lead, arsenic, all kinds of stuff. So again, talk to your physician. Make sure you know what you're taking, and also be very careful, especially if you're getting it off the street or getting it in some of these I call them fly-by-night pharmacies, or a buddy that just came from another country and said, "Gee, I got all this stuff that you got in America, but I got it on a half price."
And thank you, Dr. Lawson. Let's switch gears a minute and talk about high cholesterol. Let's go to the next two slides, Simon. And we'll talk about high cholesterol and insulin resistance, especially in diabetes. Go to the slide that starts with overview. So hypercholesterolemia is high cholesterol, especially the LDL, which is low density lipoprotein. We know insulin resistance is when cells don't respond to insulin properly. Together, they create a vicious cycle, often leading to type 2 diabetes itself. Both conditions accelerate cardiovascular disease as well as metabolic syndrome. So cholesterol and insulin resistance, LDL and triglycerides deposit in the liver, muscle, and pancreas. We know that fat and cholesterol interfere with insulin signaling. It leads to glucose not entering cells properly, and therefore the insulin is called resistant, but it means it can't get into the cell. It's like a lock on it. And therefore the pancreas will produce more insulin to compensate for that.
You're on the next slide, Dr. Maxey.
Okay.
There we go.
Okay, go past that one and go to the next one. And maybe Dr. Hines can take this one. Inflammation. Next slide, Simon.
Inflammation and oxidative stress. So, oxidized LDL triggers immune activation. And chronic
Oxidation is like rust, right? Like rust on steel.
repeat that.
I said oxidation is like rust, right?
Rust on metal.
Oh, yes, 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 yes. So, okay, so for my organic chemistry folks, right? So you've got your little molecules that are out there, and then when you have oxidation, is that basically oxygen molecules will attach to um, some of the open bonds that are available. And then that is how LDL cholesterol molecules can become oxidized. When they become oxidized, then they are essentially like an irritant, right? Um, and that's why LDL is your bad cholesterol because it is prone to oxidation, right? That leads to chronic inflammation. The inflammation leads to the release of cytokines like TNF alpha and interleukin 6. And then the cytokines disrupt your insulin receptor pathways. And then that makes your insulin less effective, which then causes insulin resistance. And then the insulin resistance leads to damaging of your vessels. And then as the vessels get damaged, well, now they're more likely to be sticky and things are going to stick to them because instead of being smooth, right? As now to your point, like rust, right? Now what used to be a nice smooth metal pathway, now it's rough. So that's as things stick to it, that's where the plaques form, and then the plaques grow, and then that's how you end up with blocked arteries. And it starts in your little teeny little vessels, like the ones we talked about in the beginning, with your eyes and your kidneys, because those are teeny little
And that's
vessels.
how your calcium score goes up too when it gets involved in those plaques.
Yes.
Dr. Walks, you take the next slide if you would. I'm rushing a little bit because we're almost at the top of the hour.
Effects on the pancreas, beta cells. Cholesterol buildup impairs beta cell function, reduces insulin secretion, creates a double hit, insulin resistance and poor insulin release, pushes you toward type 2 diabetes. Next slide, please.
Hey, Dr. Lawson, you take this one?
Vicious cycle. Insulin resistance goes to higher blood sugar. Hyperinsulinemia goes to more cholesterol and triglycerides. Hypercholesterolemia worsens insulin resistance. Cycle fuels diabetes and cardiovascular disease.
Okay. Want to take the next one? Dr. Lawson?
Clinical consequences: type 2 diabetes, cardiovascular disease, heart attack, strokes, non-alcoholic fatty liver disease, NAFLD, chronic kidney disease, and that old boogaboo we hadn't heard about in a long time, metabolic syndrome.
Okay. These are some charts. I definitely need some help on this, Dr. Walton, Dr. Hines.
Okay, visual flow chart, the vicious cycle. So all the stuff that we just said in the last few slides in a picture format. Some people like words and some people like pictures. And this is a picture. It shows that you are going, this is bad. All the stuff we just said and what we're looking at now, that's why it's called a vicious cycle. These things feed into each other and make you real sick. And in many cases, so sick that you can't get all the way back to normal.
Okay.
Next slide.
Dr. Hines, with young
Yeah.
actors?
So this is a diagram of your arteries with a cholesterol plaque. So you're basically, like we've talked about, your artery is basically it's a tube, right? And then when those sticky spots that got inflamed due to vessel damage get the calcium deposits that stick to them, and then they kind of grow and grow and grow. That's how you get your cholesterol plaques that lead to uh, um, heart attacks and the strokes and things like that we've been discussing.
Got about 3 slides. Take it all the next to you.
Sure. And then, so insulin resistance. So your cells have insulin receptors, like we talked about, and then the purpose of receptors on cells is to when the product that the receptor is looking for is found, it says, okay, you can come in, right? Okay, I know you, you're allowed to come in. So when the insulin receptors get blocked, that means when the insulin that's in your body is present, your cells don't get the benefit of it because it doesn't get to recognize that the insulin is there, and subsequently the insulin can't do what it's supposed to do on behalf of the cell. And if it can't do it at the cellular level, it can't do it for your body in general.
And one more. Next slide.
And then, so your pancreas makes B cells, which is where your insulin is produced. And so when you have a buildup of cholesterol, those cells get damaged. And then, as we said before, right, then I'm not making enough insulin, and then I'm in a system where the insulin that I have, they can't get to the cells, and then this is how we're talking about the vicious cycle.
Thank you. So to go to the next one, we have some key takeaways that we want our patients to see. So high cholesterol can worsen insulin resistance, and insulin resistance raises blood sugar and stresses the pancreas. And together they increase the risk of type 2 diabetes and heart disease. Healthy lifestyle choices are important. Diet, exercise, weight control improve both cholesterol as well as insulin sensitivity. So you want to have regular checkups and medications when it's needed. Get these from your provider and doctor. Now, Dr. Walks, want to take next slide?
Sure. Key take-home messages. Obesity, diabetes, kidney and heart disease are deeply linked. That's today's key take-home message. The GLP-1s, the SGLT2s, the statins, Corindia, each play unique roles and sometimes are combined. Inflammation is a hidden driver. Treating it improves long-term outcomes, and healthy lifestyle remains the foundation. Just act right, do right. Just that's the key take-home
Especially if your
message.
first name was Dudley, right? Remember
You know
Dudley,
what?
right?
Dudley Do Right and Nell, both of them from the cartoon Dr. Maxey. Yes, I did watch that cartoon. I
And
did,
take the last
in
slide.
all seriousness, it is the basis. We talk a lot about medications and diseases, and we talk about going to the doctor and all of that. Healthy lifestyle, that's the basis of everything. Do everything you can before we go to the practitioner and ask them to make magic happen. Make sure we're doing our part.
Take the last slide.
Okay, next steps for patients and families. Ask your clinician if one of these medicines is right for you. Stay engaged in healthy eating, exercise, and monitoring your labs as well as your eye exams. Remember, medicines add protection, but you drive your health journey. All righty.
We end that with common sense and take care of your
Yeah,
health.
yes.
Well, thank you. Any comments or questions in the chat or anything we need to talk about?
There's one comment we haven't gotten to closing comments, but I'm going to link the one comment that's in the chat to my closing comments. And there's a question about, if I have, constipation, does that mean I shouldn't take some of these medicines? And that could have been, you could have filled in the blank with any, if I have nausea, if I have anything, right? And at the end of the day, this is why you have to talk to your primary care provider, right? Because it matters just as much why you have the thing, right? As it does that you have the thing. So if the answer is, I'm constipated because I don't eat any fruits and vegetables, well then that's a totally different thing than I'm constipated because I've got autonomic dysfunction and I already have a little bit of gastroparesis. Those are two very different scenarios that you want to make sure that you talk to your doctor about. And what it can, for many people who have been desperate to lose weight and have tried, all the things, right? These some of these medicines can seem like miracle drugs. I will put my bias out there. I'm not an early adopter. I tend to be somebody that hangs back a minute to see what what's what before I start using things. But I will just say, in this market, with the way that people can take their medicines and drugs and things directly to the consumer, don't get taken advantage of in that way, right? Make sure that you are talking to your doctor, somebody who cares about you and knows what's really going on with you, your whole story. And then for many of us, we are happy to work with you in conjunction. We're happy to see you get it too, right? Because if we couldn't get it for you and you found another way, great, if it's suited for you. But make sure that you just talk to somebody who's not invested in selling one more thing.
I've been reading some articles, Dr. Hines, and I knew you're a family practitioner, of people who were constipated and have had difficulty passing stool, but actually have a heart attack while at stool. Have you seen that? I have too. So it's very important that you eat right, eat fiber, fruits, green vegetables. We talk about it, sound like we're harping on it, but it's so true. And like we say, all of these things fit together. So we're probably now ready for our final comments for the day, starting with Dr. Lawson.
Just want to note that sometimes we get fixated over one thing, one element, and that treats anything. I think this is excellent discussion because it emphasized that these systems are interconnected, and that just solving one problem doesn't solve everything. And I want to make the best point about this in terms of weight. We focus on weight loss, as you said. Folks go out and get dehydrated, take diuretics, and so forth. And say, "Aha! I lost weight. Now I am healthy." That is unfortunately not the case. There's some research showing that very, very clearly. We used to do that in wrestling. Get dehydrated and make your weight and come out and load up and eat like crazy. It is again general health that's important. We're talking about obesity. We're talking about getting rid of the adipose tissue. And I've heard folks come a lot of rationalizations. I got big bones. That's why. Or I am an athlete, even though the athletic actor was rolling their eyeballs. So again, let's not just focus on one thing. Focus on the whole picture: eating well, diet well, living well. Again, all of this is associated, these conditions have been associated with increased rates of anxiety and depression. So we need to take that into account, that we're trying to get a person to quality health so that the brain works well as well.
Thank you so much, Dr. Lawson. Dr. Hines?
So there is a question that just popped up in the chat that I will use for my final comments, and it's around if you get on these medicines, does the weight come back if you stop, right? So once we decided or recognized that obesity and any of the other things that we've talked about, diabetes, chronic kidney disease, they are chronic diseases. So we have to put our mindset with regard to these medicines the same way you would with any of the other medicines that you use for chronic diseases. That's a long way of saying, yes, if you stop it, it basically comes back. And for some people, they're showing studies that for some people it comes back even more than it was before. But the current model, the expectation is for most people, same with most chronic diseases, if you start there, then we're going to stay there. And then for all the benefits that we talked about to lower your risks for congestive heart failure and hospitalizations and stroke, you would have to be on it for a longer period of time to maintain those benefits. So you should definitely consider that this will be added to my chronic regimen if we're on this pathway.
But also, if you use this period to train your appetite, train your body, you can maybe get back on less of it, or even maybe not at all. If you use this period of time that you're on the drugs to change your lifestyle, maybe you'll get back. But right now, the jury's still out on that. Dr. Wilkes.
Thank you, Dr. Maxey. Great discussion and so timely with all of the focus on these medications. I think when we go to the doctor and the doctor or the nurse practitioner tells us that we have diabetes, we have some little decrease in kidney function, and they're going to give us these SGLT2 medications or what have you. Listen to something that Dr. Hines said earlier. Dr. Hines said earlier that there are several things that the doctor may put as stuff you need to do. So I want you to go see the eye doctor. I want you to go see this doctor and that doctor. One of the things that the doctor is probably going to tell you to do is to, given where you are at that moment, what sort of exercise and what sort of eating you should be doing. So if the doctor says to you, go out today and start walking for 5 minutes and then push it up to 10, do that in addition to going to your pharmacy and taking the medication that you're prescribed. Ask your doctor for a comprehensive care plan that will maybe include some medication, but also may include a visit to a physical therapy practitioner who may help you to be able to move better, may include a visit to a dietitian that may help you learn how to eat better. There are so many other instructions. If you want your body to be able to move when you are 70 and 80, you better be moving your body at 40 and 50. Don't, if one more person tells me, you know what, Dr. Walks? Ooh, when I retire, I'm going to get in shape. I'm going to punch him in the throat. Stop telling me that because it's not true. I don't believe you. Stop telling me that. I'm sorry, Dr. Maxey. Go
You're
ahead.
making me laugh like that. So the real message, Dr. Walks, I believe, is if you're 15, 19, or 20, 25 years old, you need to get in shape then and stay in shape, and you won't need to take all these medications and have chronic related diseases. It's so important
No,
to take
wait,
care
wait,
of your
wait, 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 Dr. Maxey, let me interrupt you. We are seeing 7 and 8-year-olds with type 2 diabetes. So, no, don't let your kids and grandkids get to the point. Okay. So,
body.
don't, no, start them early.
Start them early. Take care of yourself. You're wonderfully and fearfully made by God.
Amen.
Take care of it. Amen.
Amen.
Have a great
Amen.
Sunday. Simon, thank you so much. Have a good day. Sorry we ran over time a little bit. We'll be back next week. Have a great day.
Good day, everyone.